So, just a short video. I wanted to share with you my experience on psychiatry and my placement, what I got from it, and this will hopefully serve the purpose of you identifying what you might have gotten from it, what you might expect from it. But this is very briefly a very short video indicating or otherwise outlining the key learns that I got from this. Amongst others, I mean, I'm not going to go into any psychiatric conditions. I'm not going to go into any of that stuff at all. I'm not going to go into any physiology, pharmacodynamics, pharmacokinetics. This is purely appreciating, in a nutshell, what I got from the placement there. So, first and foremost, just to help you understand the setting I was in, this was, of course, I'm not going to reveal exactly where it was, but it was an intensive care unit, a psychiatric intensive care unit, what we refer to as PQ, IEP, ICU, and I was also on the acute wards. Whilst there, I had the privilege of also going in along to one of the rehabilitation units, in which they had one patient that had been in there and was an inpatient and is in the foreseeable future going to remain a patient for as many as 11 years. I think the longest they had there was 16 years. Yes, absolutely, 16 years of being an inpatient in hospital. I would be under the impression that patient was not discharged, the 16-year patient, but certainly this patient that had been here for 11 years is still in and will remain an inpatient. Okay, quick one there on the back of that then basically is why is the patient in there? The reason being patients who go into psychiatric units, certain PQ, acute, when they step down into the community, so a CTO, CTO is a community treatment order, and patients who were sectioned, which was very much the situation here. So all the patients here had been sectioned, and I'll go into the section in a moment. The treatment is stepped down to CTO, etc. Failing their compliance or failing adherence to the CTO, what then happens is the treatment is stepped up again. A good 50% of the population, as per the advice I got from the consultants, was that they'll recover. Of the remaining 50%, approximately 35 will recover, except partially. They'll be on a CTO long term, they'll be sectioned repeatedly, etc. And the continual care for them. But then there's a minority, a very small percentage, that unfortunately will not survive in the community, will not return to normal health, as we might classically call it. And those patients, it is those patients who then end up in the rehabilitation units and can be there for a significantly period of time. Okay, so going on then into the actual units, few bits and bobs of sections I'm going to start with first and foremost. So sections that I found I needed to be most familiar with, the terms that were thrown out there, a section 5.4, and this is a section done so by the nurses, and it allows you to detain the patient for up to 6 hours. Then you have a section 5.2, and this is you're able to section the patient if you're a doctor, so you have to have authority. So section 5.4 is done by a nurse, a section 5.2 is done by doctors, and the difference here is the nurses can detain up to 6 hours, whereas the doctors can detain up to 72 hours. So detention essentially is so both of these 5.4 and 5.2 essentially, in summary, are the ability to temporarily hold the patient, and what you're in essence doing is buying time to be able to actually put other sections in place. Okay, so the patient is ill, you consider them to be ill, and what you've got to do is the quickest ones you can do is 5.4 and 5.2, 5.4 by the nurses, 5.2 by the doctors, 6 hours and 72 hours respectively in terms of the duration of the section, and in essence it's a temporary holding by law, of course, and you are there able to buy time to put other sections in place. So what sections might you put in place there? And again, I'm only going to give you two here, and the main two sections are section 2 and section 3. Okay, so section 2 is primarily around assessment, and it's assessment oriented. Section 3 is primarily treatment based, so it's treatment oriented. And again, the difference here, and these are all done so by the doctors, of course, now. A section 2 is not renewable. A section 3 is renewable. And a section 2, this is the most important bit of it, lasts 28 days. And a section 3 lasts 6 months. When I say it lasts up to. You don't have to hold the patient for that period of time altogether. If the patient is getting better, of course, you've treated them, they're getting better, of course, out they go. And when I say out they go, it depends how you want to step down the treatment and the care that is. Okay, so that essentially is those two sections, 2 and 3. After that, what you've got is articles. I'm not going to go any further section. There are other sections, just if you want to look at section 35, 37, and section 135, section 136. Okay, so in fact, I will. Section 35 is more so to establish a diagnosis and fitness to be able to plead in court. Section 37, also known as a hospital order, where the patient is sent to hospital instead of prison. And this is by the court. Why? Because, of course, there is concern for public safety. Okay. A section 41 is a restriction order, which is similar to equivalent to like a community order. Basically, a patient is allowed to go back in the community, but with restrictions. Okay. 135, 136. 135 allows the police to arrest the patient from home. Section 136 allows the police to arrest a patient from anywhere. And these are all very important sections that you should know. Okay, articles, and I'm only going to give you 2 articles because these are relevant. Article 1, and I'll say what it states: all humans are born free and equal in dignity and rights. So basically, you cannot detain a patient. If you detain a patient unlawfully, then you are impeding on their Article 1 human rights. Okay, so that's illegal. And the other article that's really important here is Article 3, which states freedom from torture, inhumane or degrading treatment. So essentially, again, if you are detaining patients in a psychiatric setting, then if you're doing so and the section has lapsed and you've still got them in detention, that again becomes an illegal detention. Okay, so the question is, why would you detain a patient? And the purpose of detaining a patient is essentially because they are unwell. So again, going back to psychiatry, a patient should be able to understand, retain, weigh and convey. Okay, remember, in any setting rather, a patient, when you're consenting patients, they understand, they retain, they convey and they convey. Okay, so they understand the information, they're able to retain the information given them, they're able to weigh it up, whether or not they want the treatment, and they're actually able to reiterate the information back to you, regurgitate that information, they are able to convey that information back to you. And if they're able to do that, they have capacity. If they're not able to do that, then they're lacking capacity. And in the context of psychiatry, or psychiatric health medicine, what happens is, if these patients, which the vast majority of these patients who are being sectioned are, that's why we then section them, because the section allows us, that detention allows us by law to be able to intervene in the best interest of the patient. Of course, you've got to justify your interventions, or the pharmacological or otherwise, and that pharmacological intervention, which usually is the situation, has to be justified. So that's what this detention allows us to do. The purpose of detention is to actually hold the patient and lawfully actually intervene without them. So when you go to the docs, they say, I'm going to stick an injection in, am I allowed to do so? They'll, again, give you the information so you understand it, you retain it, you weigh it up, and you convey it back to them. In this situation, they're not able to do that, but they need the treatment. So therefore, the section allows the doctor, the medical staff, to do so, to actually intervene medically by law. And that's essentially what this is. Okay, moving on from this stuff. So the actual antipsychotics, what I saw in these settings, and so just to remind very briefly, there are typical antipsychotics, atypical antipsychotics. I'm not going to go through these, you can Google these, but the ones I've typically seen in the community practice, haloperidol and chlorpromazine, they're the 2 main ones that I've actually seen and dispensed in the pharmaceutical setting, the pharmacy setting rather. The atypicals now are becoming more used, and these are of greater value really. So these are the ones I actually saw predominantly in the ICU. So there was olanzapine and clozapine, there was quetiapine, aripiprazole and risperidone. These are the 5 that I saw mostly. So just to put into context, antipsychotics usually have an antidopamine effect. Aripiprazole is usually the first line or used most. Why? Because of its cardioprotective properties. but it's relatively ineffective. Okay, certainly in that setting. So you just need to be mindful. Quetiapine, this one and the way to is important. So just before we move on to the individual ones, all antipsychotics have side effects, all drugs have side effects predominantly. The main side effects in antipsychotics, you want to look out for prolonged QT interval. You want to look for hyperprolactinemia. You'll want to look for EPSEs, meaning EPSE, as in extrapyramidal side effects. And you want to look out for NMS, neuroleptic malignant syndrome. Okay, so I'm going to now go into a little bit of that. So aripiprazole, we already mentioned. Quetiapine is actually the most notorious one, which will cause a prolonged QT interval. The QT interval is important. So when you look at the ECG, you then have to calculate the corrected QT interval. And again, for males, it is in the region of 450, for females, 470, but this varies as per reference. Prolonged QT, usually over 500, becomes clinically significant. The importance of that is that it will lead to a complication known as Toussaint de Poix, which is a fatal ventricular arrhythmia. And when I say fatal, it's fatal. So that's what we're watching out for. And quetiapine is the most notorious to cause QT interval prolonging. So the way to remember that QT and then the QT in quetiapine. Okay, the olanzapine and the clozapine. Okay, so these two are important. Olanzapine is used relatively. Clozapine is kind of the last line from what I recognized in there. With clozapine, the problem you have is with both of these really, but clozapine more so, agranulocytosis, and so we've got to be very careful. We've got to do regular blood checks, and we're checking the white cell count. We're looking at the and making sure there's no neutropenia going on. Okay, so that's that one there. Okay, other drugs that were used here in the same setting was promethazine and promazine. Now, promethazine is actually antihistamine. So the question, why are we using promethazine? Well, it's for the agitation and the anxiety. So there are patients who will come in and they've got psychomotor agitation, which essentially means that they're unable to stand still, literally are unable to stand still. And they can come across as being relatively aggressive, and that's what that's used for. And then you've got promazine. Now, promazine is used for similar thing, agitation again. However, this is more so particularly for that agitation which is drug withdrawal induced. So if you suspect somebody is experiencing withdrawal symptoms of drugs of any sort, and I mean street drugs here, such as cocaine, heroin, etc., then in that situation promazine is usually better. Hyperprolactinemia, so prolactin, remember, I'm not going to go into it, but essentially when we're assessing the patient for hyperprolactinemia, first and foremost the levels. So when we do regular blood tests on these patients, that's one of the things we always measure, prolactin levels. So we set a white cell count because of agranulocytosis. We're also going to check prolactin levels. When it's over 1,000, it becomes clinically significant. In the norm, it should be less than 400. We can ask the patient about symptoms of hyperprolactinemia. That's nipple soreness and discharge. Interesting, the treatment for this is in fact aripiprazole. So you will actually give another antipsychotic to counteract this hyperprolactinemia. Another side effects are the anticholinergic side effects. So you know this one: blurry vision, dry mouth, difficulty in urinating. So we will address those, and the EPSEs, the extrapyramidal side effects. So what are EPSEs? Extrapyramidal side effects, and I'm going to give them to you in order of occurrence. So you've got acute dystonia, you've got akathisia, you've got Parkinsonianism, and you've got tardive dyskinesia. And they come in that order, and it's hours to days, days to weeks, weeks to months, and then 6 months plus. Okay, so I'll go again. Acute dystonia, akathisia, Parkinsonianism, and tardive dyskinesia. You can read upon these yourself if you so wish, but that's the duration in which they occur also. So how do we treat these? Well, we'll give procyclidine, or we might even give quells. So you can buy anti-sickness tablets over the counter called quells. That's hyoscine hyoscine hydrobromide. The procyclidine is an anticholinergic. Okay, so that's basically the cholinergic receptors in the basal ganglia is what it enables to block them, and therefore blocks the anticholinergic effects. Okay, we've already mentioned QT interval, and I've already said QT, if it's more than 500, it becomes clinically significant. And the final thing I'm going to mention is the neuroleptic malignant syndrome. So if a patient on antipsychotics speaks to you about sweating, chest pain, or you recognize an increased pulse, then you want to consider neuroleptic malignant syndrome, in which case you send them to emergency medical care. So that's essentially what I got in a nutshell. I mean, there were lots of other learns, of course, but these are the findings, the learns that I considered to be of most importance for an examination setting, and most importantly for you to appreciate when you go on placement. It would be a good idea to have these kind of things in your mind, and recognize that. Of course, don't forget, like I said, I'm not going to go into conditions. Be sure to know your personality disorders. Be sure to know the schizotypal PDs, and then after that you want to know the schizophrenia, schizoaffective disorders. You want to know the individual personality disorders and how they might manifest, or traits of. Appreciate all of that, and don't forget the very basic first rank symptoms, second rank symptoms, and the likes of these information. I hope that's been helpful. Feel free to share the learns in a similar fashion, and I hope it serves a purpose for your placements. Thank you very much.